Thanks, Ish, for inviting me down here. Sorry I couldn't be here this morning. I think there have been some really great presentations today, very, very data-driven presentations, and I really enjoyed some of the technical aspects of the presentation that we've just seen. I think, as you'll see from the way that I do minimally invasive surgery, that there will be some big differences between our thoughts on this. And I think that's just down to, I think, probably philosophy, maybe a bit of vanity, and also perhaps the way that it was introduced to me maybe a decade ago now by Hugo van Herman. And of course, back then, the way I learnt minimally invasive mitral valve surgery was quite simply to go and see him 2 or 3 times, and then do a few cases with Dave Richins, who'd done a few in Nottingham. And that early experience was a really trialed and troubled experience. I look back with perhaps a decade of maturity today. And I've come backwards from endo balloon to porta clamp, which is a plastic version of a chipwood clamp with aortic cardioplegic delivery, and then spun right back round to the new intraclude device, which actually has surprised me enormously with its efficacy and stability when positioned appropriately in the aorta. I'm not going to talk too much about the technical aspects of it today because I've not really been asked to do so. I've been asked to talk about the way that one might think about building a minimally invasive surgical program in the current economic climate. We know it's a difficult one. It's very interesting that the politicians that dictate how much money gets spent in the NHS are giving themselves a backdated 7% pay rise. Very interesting there. But nevertheless, that's where we are. And I guess what we have to do is go back to why we might be wanting to do minimally invasive heart surgery. I'm going to confine myself to the mitral position, but I think that this is true of many other areas. And one of the big areas we're beginning to see that's of great interest to patients and to clinicians, cardiologists and cardiac surgeons, is the era of hybridization of treatment strategies. And I think that if you're not on the platform of minimally invasive cardiac surgery to start with, then all of that is a non-starter. So this is a slide you may have seen many times on the internet. This was drawn by my son, who's an artist. He did a very good job. In the early days, the little cut on the mini thoracotomy patient was much bigger than this. And I think that that's where I talk about vanity. I don't know whether it's my vanity or the vanity of the patients, but they want small cuts. And we started with a small thoracotomy and a small retractor, moved on to the soft tissue retraction, and now for males we will use a circumferential areolar incision. And for ladies, we don't really like to cut through the breast tissue in the lady, so we'll go underneath. And I think that's dictated how we've wanted to do the surgery, and that's why intraclude, in my view, has taught us in the second attempt at using that technology that it really is the only way we can minimize the incision in minimally invasive mitral valve surgery. And of course, if we look at some of the arguments, and these are potentially sort of like theoretical arguments, we're beginning to see that some of these are now proving to be true in the literature, although not from randomized data. Stenotomy, great incision, it heals well, it's not a particularly painful incision, it's a big incision, and it takes 12 weeks to heal. And you compare that with a mini thoracotomy, there's no broken bone if you've done it correctly. It heals in 7 to 10 days, certainly less painful, there's no doubt about that. Early return to activities, patients want this, there's no doubt about that either. I think it does facilitate later surgery, and we go back to the early conversation about whether we would or we wouldn't operate on the patient with early mitral valve disease that's severe and asymptomatic. I think the key answer there for the minimally invasive protocol is that if you can do it safely, well, why not? And that preserves the stenotomy for reoperative intervention, 20 or so or 25 years or so down the line, if one believes the durability. And I have no reason to disbelieve it, to be honest, in my view. Now, of course, it's also excellent for redo surgery. It is our chosen technique for redo surgery. And then finally, I always put it bottom of the list, but it's always top of the list for patients. It's cosmetically more appealing. But austerity is a problem. We know that. I've already discussed it. So we're caught. You know, our managers are finding it increasingly difficult to allow us to develop technologies if we're interested in developing them. And I think this is what the key consideration is. A cost improvement program or protocol is what the managers love. It's anything that will save us money, is how they put it. Of course, from our perspective as clinicians, we're interested in clinical improvement programs, anything that will improve the outcome for our patients. Now, I'm not saying at this point minimally invasive cardiac surgery does that, but I do believe it has the real potential to do so, and we're beginning to see in experienced hands that it does do that. And of course, an ideal improvement program is one that delivers both. And there's very few of those around. But if you're smart, you can actually convince managers that whatever clinical improvement program you want to deliver actually is also a cost improvement program. And I'll demonstrate that to you now. I put the economics of minimally invasive surgery in terms of the slides I'm going to show you together in less than 5 minutes. And I did it deliberately like that because I wanted to show you how easy it would be, I think, to convince your clinical managers that they can afford this. Now here is the added price of intraclude. I don't know whether you can see the prices there, but the biggest price there is the intraclude balloon itself, which is about £1,700. Now, if you use a Chitwood clamp, it's a reusable clamp, and a direct plegic protocol, then that's a cost that you wouldn't have to bear. But let's take the worst case scenario. My perfusionist put this together as the added expenditure for each of our intraclude cases that we do in Essex. And then I just downloaded this slide. We may have seen some of this data before. There are two meta-analyses that I found in the literature. I found them very quickly yesterday. They both say roughly the same thing, that the cross-clamp time and the bypass time is extended, and I think it's very important to recognise that, and also therefore to recognise that when you choose your patients for minimally invasive mitral valve surgery, you choose the good ones, the healthy ones. And of course, we routinely scan aortas in all of our patients. We did that even when we were using the Porter clamp, quite simply because we were concerned about retrograde perfusion of the aorta, and we will not retrogradely perfuse an aorta that is significantly atheromatous within its lumen. And that has meant that we haven't seen stroke. And in the 60 intracludes we've done in the last 9 months or so, we've seen no stroke. We will not operate on a patient who's got atheroma though. So I think that's the key consideration that we will put all of our patients through. Now, if we look at this data here, I mean, the only thing that I wanted to concentrate on here was ICU stay. There seems to be a reduction in ICU stay that doesn't translate into length of hospitalization. But a simple calculation there will give you an idea of what that cost saving for an organization might be. It's a hypothetical one because when you learn to do minimally invasive mitral valve surgery, you'll be doing 1 case a day. So you're actually losing a case a day. We actually do 2 cases a day in our organization, and we've been smart about how we've put that together. Then you look at some clinical parameters that might suggest that there's some good things for the patient. And here's a non-randomized piece of work, 1,000 cases compared retrospectively, patients who'd had minimally invasive surgery versus stenotomy. And we can see that the time to independent ambulation and time to independent sit to stand was clearly significantly better in the minimally invasive group. Very easy piece of data to find. And then finally, this very same piece of data did a bit of a cost equation. Again, retrospective, non-randomized. It's difficult to be sure that this is the case, but here we have it, a median saving of just under $7,000. So here you have it. There you go. There's your business case that supports the costliest potential argument for the use of intraclude. Now, that may be an irresponsible way to demonstrate a business case. And I did it deliberately irresponsibly just to demonstrate to you actually with a bit more diligence, I think one can still put together a coherent argument to introduce a minimally invasive program on an economic base. But I think that's not the reason that I should be presenting what I'm going to present to you today. And that's in relation to my experience in the area. I think what's more important is this. Building a minimally invasive solution in the current clinical governance climate. And I think that that is what we need to consider today. And there's a big game changer, something that's very different to the way it was 10 years ago, and I'll try and demonstrate that to you. So when I started the minimally invasive program in Nottingham, I had a senior consultant there, Dave Richens, who I thank enormously for his assistance in those early days, and Steve Hunter, who came down to assist me. He watched me do a couple of cases and then left me to it. We did about 18 or 20 cases there. We chose high-risk cases, probably not the thing we would do today. And the results were acceptable when one compared them with the risk cohort that we were operating on, but the learning curve was enormous. And then, of course, we jumped down to Essex, where they wanted us to deliver this program, and I've been doing that, this program there since 2007. And I realized a few things. The first thing is you need to have a high concentration of patients. You need a large volume of patients. And the only way you're going to do that is to ensure that what you have locally is super specialization of the mitral program. And we put this into place day one in the Essex Centre. So every single patient with mitral valve disease that was referred to the centre would go through the one-stop mitral clinic. Some of you may have seen this slide before. It's still true to today. In fact, it's even more powerfully true today, and it's been enormously helpful in creating this multidisciplinary approach to the treatment of diseases of all types. And we've moved this into the aortic arena too, for the minimally invasive aortic and the sutureless valve program too. So we look at indications for surgery, we look at guidelines and decide whether repair is appropriate at this point or not. We look at associated procedures like AF ablation, closure of the left atrial appendage, tricuspid procedures, and then finally we talk about the approach. Is it appropriate? Is the CT scan acceptable? Is the patient suitable for the procedure? And I think that by doing it that way, we've had a huge amount of governance support within the organisation itself, all the way filtering to the medical director. And I think that's really important, step one. But I think this is the game changer for us now. I think this changes the way that we deliver a very difficult learning curve. And I think that it'd be fair to say, and I'd be interested to know what the other minimally invasive mitral valve surgeons think in the room, but minimally invasive aortic valve surgery somehow seems to have disseminated much better than the mitral valve, and it's quite simply because it is easier to reproduce. That's not to say that everyone, that only certain people can do this procedure. I think the majority of surgeons today, certainly in the UK, can do minimally invasive mitral valve surgery, but it's just how we're going to disseminate it. Let's look at this piece of data, and I think this is a very important piece of experience from Leipzig. And I think when I read this paper, and when everyone quotes this paper, they talk about the X number of cases that someone must have to do before they start to look competent. But I read this paper and I see something even more fundamental than that, actually even perhaps a little bit scary, to be honest. I don't know whether you can see the numbers here. If you can't, it doesn't really matter. Because what I'm trying to show you here is the experience in Leipzig. We all respect that experience. From 1994, I can't read it myself, to 2011. So back then in 94, 20 mitral valve operations, N equals 1 minimally invasive. 2011, 476 mitral valve operations, 380 minimally invasively. A total experience of just under 4,000 minimally invasive mitral valve procedures. So suddenly from 5%, well, you can't really call that a percentage, all the way now to 74% of mitral procedures in Leipzig are done minimally invasively. So I think that what we've got here is a unit that's very credible, like the unit that we've just heard from. If we then look at the complications by number of case, this is the sort of thing we start to look at. And we look at complications like bleeding, like new requirement for hemofiltration, reopen, conversion to stenotomy. A whole compendium of complications, not just death or stroke. So we can be even more fundamental about some of the misery that minimally invasive mitral valve surgery puts a clinical team through as they learn this procedure. We can perhaps see what a learning curve might then look like. So we look here now. These are individual curves from Leipzig. And they're example curves, but they're real curves too. So that what we have at the top is a typical curve. So what we see is the curve rises as we see that the surgeon or the surgeon and the clinical team are perhaps not performing as they might be expected to do, but then there's a rapid decline in that curve, which demonstrates what you'd expect from a typical learning curve. The second one is a surgeon who's outperforming. He hasn't had much of a learning curve, or she hasn't had much of a learning curve. And then we've got the third one that is a rising curve. If we then move on to look at this curve, this is the institutional learning curve for Leipzig over time. And there's some dots there that demonstrate to you when new surgeons were brought on board to learn the procedure. So you see early on, there's a slight rise, then the curve falls, and then we have in 2000 another surgeon, 2001, just under 2002, it sort of stabilizes, then it starts to fall again. There seems to be some other surgeons involved, and then there's a whole barrage of individuals that start to get involved, and the curve rises. And if we take it, if we sort of separate all of that into individual curves, this is what it looks like. So we see a whole bunch of little rising curves. The interesting One is that even within the Leipzig Centre, there will be surgeons who might underperform, and there will be surgeons who outperform or overperform. So even in an infrastructure where there is a lot of experience, even in an institution where there is a real depth of knowledge about this procedure, there will still be individuals that will not be able to deliver this within the confidence limits that one would be happy with. Of course, this is a very responsible way to see that so that one can address it quickly. And you know, when Professor Moore presented at the Society, I was very impressed to see the mechanisms they had in place to ensure that they could correct that. So it's good to know that it can be corrected. I think what I'm really trying to say then with this data is this, is that it is no longer possible to learn this procedure by visiting a unit and seeing one or two of these procedures, to invite a mentor to take you through one or two, to then start a program and hope you're going to be okay. And of course, I've learned from bitter experience myself that despite the fact that we have now developed within the Essex Cardiothoracic Centre a real depth of understanding and experience, and I think the Intraclude has brought this multidisciplinary approach that has created a greater level of expertise within our organisation personally. I can't reproduce that expertise even with the same teams in another organisation. So I think institutional risk is also very important. So this was something that we were having a conversation about, this Leipzig UK, in inverted commas. I'm not sure that's the right phrase. Slightly old slide this, there are a few more red stars on there. But we've got a nice distribution of minimally invasive experience within the UK now. And I think that those individuals that perform it have a responsibility to help to disseminate the learning. And I think that I know my organisation would have no problem with supporting a local organisation that wanted to learn minimally invasive mitral valve surgery. And I see no problem with teams getting together within an infrastructure that's been delivering this for a decade and over a period of time, not 2 days or 2 weeks or a couple of cases, but over a period of time that could even be as long as a year, learning the various steps that will ensure that we deliver minimally invasive mitral valve surgery as a UK Leipzig much more responsibly than perhaps we had done in the past, and I don't absolve myself of that responsibility, by the way. And of course, remember, this is really important. I think that at the end of the day, this is what patients want, and we as their clinicians have to find a way to deliver an advance in our technology, an advance in the way we do things within an environment that ensures that it's also safe, so that it really is an advance that they can benefit from. We've been to the Society meetings, and I'm really pleased that the Society have supported this meeting today because it's an understanding from me that there is a recognition that the minimally invasive platform is really important for us. It's going to play a very vital role in cardiac surgery going forward, and I think those individuals who are not involved in it now, or refrain from being involved in it in the future, will find themselves, quite frankly, out in the cold when it comes to delivering this. There has to be a national approach to training and development for the more difficult procedures, there's no doubt about that, and I think minimally invasive mitral valve surgery is one of those. And I'm pleased to see from today the greater level of support from industry and the society in putting together a group of individuals interested in minimally invasive surgery, because it convinces me that there will be a future for the specialty in the UK. That's all I wanted to say.
Okay, thank you both. Can I invite questions from the floor, please? Shall I kick off? I think you both brought some really interesting points up, and there's a whole bunch of questions I could probably ask. But let me go to one that's on my list, and that's about the techniques that you use to repair the valve. When you moved from open sternotomy mitral surgery to minimal access, did you change the toolbox that you approached the mitral with? Did you change in any way how you did your operation? Did you use more Cordy? Did you do less resection? How did it impact on that? Both of you.
Well, for me, actually, we haven't changed it, but we definitely, at the very beginning, we started selecting patients. Of course, we didn't start our program with very, very complicated procedures. but in a very short period of time, we were able to perform any procedures. We recently moved to more neocordia because there is a changed paradigm in respect than resect. In the past, we used to resect a lot more. Now we implant more neocordia, but it's not relative to the approach actually. As long as you work, you learn working with long instruments, I think you could do whatever, actually.
I think that I always used to use a band for degenerative. I use a CG band. I like the AP diameter. It's narrow. If I use a Physio 2, I always see at the end that small bit of central regurg. It seems to go away, but whenever I use a CG band, I never see that. In annular dilatation or in AF cardiomyopathy, I use an IMR ring. I've always done that. I continue to do that. The posterior leaflet, I moved away from quadrangular resection a long time ago, and for the minimally invasive, I think that certainly as you restrict the view, resecting isn't easy to do. And we went to cords long ago, the Perrier protocol, to be honest. It meant for me I didn't have to go through the dilemma of worrying about the height of the posterior leaflet. I'm going to pull it back with cords, I'm going to put it in, it's not going to be a problem ever. And so for a P2, the typical thing to do is find the two heads for the posterior leaflet and triangulate two cords. That's it, simple as that, with a pledget non-tied onto the head. And then for the band or for the ring, what we've learned is that I don't use different colours, I just use the same colour, and we put them in a pyramidal manner. So stitch, stitch, stitch. And then when you look through the telescope, they just look, the two stitches that belong to one another look obviously like they do. We've moved away from knotting to the use of core knot. And the way we did that was we said that this would save us 20 minutes, and that would mean it would be much more likely that you could freely schedule any case on my list as a second case of the day, as opposed to only a Q2. That was a sensible and strategic way to introduce a bit of new technology. And actually what we found with that is that it's a very reliable tool. You snug it down, you shoot the gun, it clips the clip and cuts the string. And I think the feedback you get when you tie with that one simple maneuver is very straightforward for the ring. Yeah. For the leaflet, you knot tie. And once you've learnt to knot tie on a leg chair, for a couple of months, it's very easy to do. There's no doubt about that. The hardest part of minimally invasive is the 2D stuff. But if you do a lot of VATs, that you already have that skill. And then it's just a case of getting used to it and starting big and shrinking down as you get more experienced. So the fundamental aspects of the repair we've not changed. Until recently, we wouldn't repair bileaflet, but we would repair bileaflet through the breastbone. We are now increasingly repairing bileaflet. The anterior leaflet, if it's isolated and triangular in nature, is very easy to repair through a minimally invasive protocol because the vision is so much easier. Posterior cords, much more difficult to get in and find that head and put it in, whereas the end you just lift it up and it's just there. It's unbelievably easy. So that's how we do it. So some changes, but only subtle. Yep.
Changes in tools more than in
yeah.
In that, obviously you are now well over your learning curve, so it's relatively easy in the position you are. I suspect one of the biggest problems going forward, as you touched on, is the governance of this, of centres and surgeons starting it up. We're all aware over the last few years in the UK of individual patients who have died probably as a direct result of problems with myocardial protection or whatever through minimally invasive mitral valve surgery, and of individual surgeons who've been suspended from practice because of that. And I think that for colleagues around the country is a real stumbling block of proceeding with this. How do you, as someone now who's established it, would you be able to do it the same way now as you did 10 years ago? Or do you think it would need to be different in the current era?
I think that my presentation says exactly what you just said. I think that if I were to start it today, there is no hope of me being able to start it.
You couldn't do it the same way you did it.
I couldn't possibly do it this way. And if we go back even further into the era of the beginning of cardiac surgery, Some of the things that have brought great value to what we do today was delivered with little or no governance framework. That is clearly not correct for today. I'm not even suggesting for a moment it was correct for yesterday. But I think we can learn from some of those. And I think that, you know, there was a time when I was training that mitral valve repair in itself was the big question mark. And I think no one's questioning it now. And there is no doubt there will be a time when what we're doing today, the few of us that do it, and I think the many of you that you actually want to do it but have this one fear, will realise actually is now just routine. And I think that some of the new technologies, we're evaluating the Memo 3D record, which you may or may not have come across. We're going to put in 25 into humans. There's a CE mark for this. You can put it in tomorrow. They're a Sorin derivative. It's an established ring. It's a soft ring, a flexible ring. I don't like it because when you put the stitches in, it doesn't go in easy. But it's got this little device on the back that allows you to very easily and very reliably exactly measure and tie down the length of the cords for the various parts of your leaflet disease. I think it's been very useful for bileaflet disease. And I still haven't had the courage to do it in the minimally invasive setting. I've used it, but not actually used the system, because I use my eyes. And actually, that's even easier. Trust me, it's just so easy you wouldn't believe. But I think it's a way by which I think it's a great technology because it will allow those surgeons who don't do a great deal of repair to be a lot more confident about using cords to repair leaflets. And then as you move into the area of minimally invasive, feel more confident in time about its use.
Yes. Well, I think that memory cord actually helps minimally invasive because you have less problems in setting the right point of coaptations. You have, once you get used to, I look inside as well, so I do not use that, but I think it can give you a great help in minimally invasive.
Andy, can I ask you a question? Somebody that has brought in mini AVR and mini mitral into your unit, just reflecting on Inda's comment about why the mini AVR has taken off a lot quicker and probably more successfully than many mini mitral programs. What is your reflections on how you built both of those parts of?
Mini AVRs is much easier to do than mini mitral. Conceptually, mini AVR, certainly if you're doing it through a mini stenotomy, is only 2 or 3 steps away from a conventional AVR. We run the training course in Middlesbrough for people to come and watch, and I think you can show somebody a couple of cases and then you can go and proctor them doing 2 or 3 cases. And the difficult bits of the operation you can teach very quickly in somebody who can already operate. Whereas mitral, there are so many extra steps for surgeons who are used to operating through a big hole to suddenly be doing it through a tiny hole and operating on a video screen and using long instruments, using core knots. So you could list 12 or 15 different parts of the operation which are totally different with minimally invasive mitral, whereas there's only 2 or 3 things with the mini AVR. Even simple things like tying the knots with doing an AVR, it's all done with your fingers, whereas with a mitral, it's all done with knot holders, and it's, unless you've practiced a lot in a wet lab or, as you say, around a chair leg, there's lots of bits to add together till you get smooth. A mitral surgery does take a lot longer. It tends to take all day to do a mini mitral when you're learning to do them, whereas an AVR you might only add 20 minutes or so onto the operation.
Yeah.
So those around you, there's pressures on waiting lists. Those around you will complain that you're only doing 1 case a day, not 2 cases a day. So although you're trying to demonstrate you're saving costs, if you do 1 less operation every day, that's quite a big expense to make up.
But if you consider mini thoracotomy for AVR, that is completely different question. Yeah, it is definitely easier mitral procedure than aortic valve replacement through thoracotomy, at least with no sutureless valves. So that's why because we started with the mitral valve back in 2003, and we moved 3 years afterwards to minimally invasive aortic valve replacement through mini thoracotomy. So that's why probably we learned it better, and we felt better with mitral. But absolutely compared to mini sternotomy, AVR is probably is probably the best to start with, if you want.
Can I just ask a practical question? Are you still doing your other forms of daily surgery, like coronary artery bypass surgery and emergency surgery? I know you, yourself in Essex. Are you doing that, or your everyday other forms of surgery?
Yeah.
Does it have an impact on your colleagues to any degree?
I think the impact it's had in Essex has been a positive one and a negative one. It's been positive because obviously Essex as a new organisation was right smack in the middle of really well-established and highly credentialed organisations like Papworth or the London centres. And of course, in growing something like this, we needed to recognise that we needed to compete in some way with those centres, at least in terms of credibility on a very basic level. So as we've evolved, we've dealt with the basics. But in addition to that, I think we feel extremely secure and protected in some areas. And those areas are, quite specifically from a surgical perspective, the minimally invasive remit. With the new centre, the Barts Centre, Barts Health, which is now going to be one of the biggest centres in Europe, if not the biggest centre in Europe, there's a huge threat for organisations around it. Perhaps not Papworth, because your credential is written in stone now, but not for us. But one part of our establishment that will always be fine will be our minimally invasive program, and the mitral program is strong. Year on year we've grown, and so the negative part of it all is we're in a situation now where we need to train up surgeons to do minimally invasive surgery, and that's going to take time. And so we're in the process of training our consultants in-house. We've started with the minimally invasive aortic work, and we're moving to anterior thoracotomy now with the sutureless valve program that we started about 7 months ago. But the mitral program is going to take longer for us to develop an in-house, credible second individual who doesn't just come and do it with me, but actually deals with the volume of work that's coming through the door. So that's a negative of it all. And then we've also got the other two areas that we haven't discussed here, of course. We have a big mid-cap program, and we have now a growing interest from our cardiology networks and patients alike in hybridization of therapies. And there's some very interesting data that we reviewed recently at one of our cardiology MDT meetings, looking at the 3-year outcome, comparing, and some of this is randomized data, by the way, comparing multivessel grafting in triple vessel disease through a stenotomy with hybridization, which is limiter LAD and multivessel stenting. And the 3-year outcome data looking at major events, MACE rates, no different. But what is different is that early recovery in competent centres that do a lot of mid-cap, and there's no reason why all of us can't have competent centres that do mid-cap. It's a learning curve like everything else. Those patients recover better. They bleed less. They get out of hospital sooner. Our mid-cap patients go home on day 2, day 3. The thing that stops them is AF. We've started using sotalol, and that just takes it away. And so suddenly, your organisations are seeing that they're getting tariff, but what they're actually also getting is better throughput because you're clearing your ITUs and your wards quicker. So the financial incentives for them are great. We have had to go to special commissioning for this because by doing them as one-stops, all in one go in our hybrid suite, we've had to find a way for that to be commissioned because until now that's been something that hasn't been done in the UK. But it's been done extensively. I mean, what I'm talking about, I feel embarrassed when I sit next to a gentleman like this talking to him about this. These guys in Europe and the US have been doing this for years. Not all of them have been doing it well because of the governance weakness outside of the UK. But actually, if we understand what governance means and we work together as a society and as a group of individuals across the country, I think that we can find ourselves in a totally different position in 5 years to the one we find ourselves in today. If we're in the same position 5 years from now as we are today, that would be a dreadful shame. I know one thing, Essex won't be, Middlesbrough won't be, Blackpool won't be, Liverpool won't be, hopefully Brighton won't be, and a few of the centres that I may not have mentioned yet, because they're involved in this and they understand how important it is to move it forward.
Can I just make a comment on the statement that starting a mini mitral program is more difficult than we have a humble experience in Aberdeen. We started these procedures in about 4 or 5 years ago. We've done about 80 90 cases, and I rarely do an isolated mitral nav through sternotomy. I give credit to MASA technique, which really made it very simple for the average surgeons like myself to adopt a mini-mitral approach. They have a direct vision policy, so the camera is just for the fun of it or for the audience in theater. So we do everything really with direct vision. Yeah. And the more you do them, you find it's actually easier than a sternotomy. Yeah. I found that starting an aortic program is more difficult than the mitral. I don't know about that, but hoping to start many aortics, but many mitral, I don't think it has been any difficulty in that. And with the core note, I would like to add, it's not a time thing. It's not only time issue. It's actually technically simplifies the operation and negotiates areas that it would be difficult to put your note pusher in or your finger in. I use it even for open cases now, for the aortics as well, and it's made a big change in the practice.
Unfortunately, it's terribly expensive.
Well, they are about £400 or £500 per case, and if you use a lot,
yeah,
they
probably
drop
more
the
expensive
cost.
in Italy then, because
the whole operation costs £400 or £500.
No, I mean no, because we used to work with the nut pusher, and we probably save I don't know 10-15 seconds with the core knots, and it is actually works, and in all the video assisted mitrals we used it, and it was an excellent tool. But on direct vision in a normal setting, well, we probably didn't experience such a time saving. But you know, it depends on the surgeons.
But with the knot pusher, doesn't your hand get tired at the end? You don't feel
hands get tired.
Not anymore.
Not anymore.
No, actually,
with the core knot,
feel the shoulders, the big ones.
Your hands
no,
are
not
still
really.
strong.
No, it depends on what knot pusher you use, because there's the plastic one, the very first one, which is quite difficult. The one which from Cadvision or Sorin, which close the sutures in a ring, and you push it aside of the knot. Well, that is definitely easier and less stressful.
There are a few scanners, but really the core knot has made a huge change and made life so much easier.
It's just one gesture. That's for sure. Absolutely agree with you.
So I'm going to have to interrupt. It's obviously a huge topic for a short session. I hope we get more opportunity to converse and share experience again. I'm going to draw this session to a close, and I'll allow Ross to